Assalamu alaikum. Now we will start the second part of pediatric emergencies. We will talk about convulsion. Convulsions are among the most common pediatric emergencies and probably the most traumatic event to the parents. It is defined as involuntary contractions of muscles due to abnormal electric activity in cerebral neurons. Convulsions can be due to febrile convulsion, which is the most common cause of convulsion in pediatrics, CNS infections, electrolyte disturbances, epilepsy, CP, etc. Status epilepticus is a prolonged fit for more than 30 minutes or very frequent short fits that recur repeatedly without recovery of consciousness in between. Some suggested using the term impending status epilepticus for seizure between 5 and 30 minutes. Etiology of status epilepticus. It includes new onset epilepsy of any type, drug intoxication, for example, tricyclic antidepressant in children, and drug and alcohol abuse in adolescents, drug withdrawal or overdose, hypoglycemia, electrolyte imbalance, like hypocalcemia, hyponatremia, hypomagnesemia, acute head trauma, encephalitis, meningitis, ischemic, arterial or venous stroke, intracranial hemorrhage. Pyridoxine, folic acid, and pyridoxal phosphate dependency, inborn error of metabolism, hypoxic ischemic injury, for example, after cardiac arrest. Hypoxic ischemic injury and systemic conditions like hypertensive encephalopathy, renal or hepatic encephalopathy, brain tumors, and any other disorder that can cause epilepsy, such as brain malformations, neurodegenerative disorders, different types of progressive myoclonic epilepsy, storage disease. Now we talk about serious complications of status epilepticus. This includes neurological complications like cerebral ischemia, brain edema, intracranial hemorrhage, respiratory like apnea, cyanosis, neurogenic pulmonary edema, aspiration pneumonia, cardiovascular like shock, heart failure, hypertension, cardiac arrest, metabolic like hyperpyrexia, metabolic acidosis, hypoxemia, CO2 retention, hypoglycemia, hyponatremia, hyperkalemia. The mortality rate is 5 to 10% due to apnea, cardiac arrest, or brain damage. The management of acute convulsion. First, patent airway by giving oral airway and section of the oropharynx. Keep the patient on his side to minimize the possibility of aspiration. Second, oxygen therapy. Preserve brain functions and to avoid brain hypoxia. 40 to 60% with a face mask is sufficient. Third, immediate IV line. Giving glucose 10%, 5 ml per kg, and anticonvulsant drug. Then initial investigations. Fourth, immediate IV anticonvulsants. A benzodiazepine like diazepam, lorazepam, or midazolam is the drug of choice. Diazepam or Valium is given IV directly in a dose of 0.1 to 0.3 mg per kg at a rate no greater than 2 mg per minute for a maximum of 3 doses. If convulsions cease during injection, don't complete the calculated dose. Respiratory depression and hypotension can occur, especially when administered with a barbiturate. If an IV line cannot be established, rectal diazepam or lorazepam can be used safely. Diazepam diluted in 3.9% sodium chloride is placed into the rectum by a syringe and a flexible tube to a dose of 0.3 to 0.5 mg per kg. Sublingual lorazepam may be used with serious seizures that tend to develop into status epilepticus while the children are at home. Rectal diazepam gel that is distat, pediatric doses of 2.5, 5, or 10 milligram. If there is no control of seizure within 10 minutes, we will shift to the second line of therapy, giving phenobarbital loading dose of 15 to 20 milligram per kg, or in a neonate 20 to 30 milligram per kg IV in 20 to 30 minutes. Maintenance dose 3 to 5 milligram per kg per day, divided into equal doses. Phenytoin can be given also in a loading dose of 15 to 30 milligram per kg IV, 10 milligram per kg increment at a rate of 1 milligram per kg per minute. The maintenance dose of phenytoin is 3 to 9 milligram per kg per day, 2 times, divided 2 times. ECG is recommended during the loading phase to identify arrhythmias and bradycardia, a rare complication of phenytoin in children. Systemic hypotension may also complicate IV phenytoin. In status epilepticus, the initial therapy usually involves intravenous lorazepam, which is at least as effective as intravenous diazepam but has fewer side effects. The dose is 0.05 to 0.1 milligram per kg IV. In infants, a trial of pyridoxine is often warranted. If intravenous access is not available, buccal midazolam or intranasal lorazepam are two effective options. With all options, respiratory depression is a potential side effect for which the patient should be monitored and managed as needed. Nasal midazolam and rectal diazepam have also been used, but there is less evidence to support their use in status epilepticus as compared to the other options. Other options in refractory cases in ICU can include diazepam infusion, midazolam infusion, barbiturate coma, and general anesthesia. Thank you very much for your listening.